Senior Professor Dr. N. Gopalakrishnan sir, fondly known as NGK sir by the entire young nephrology community. Sir served as the former director of Institute of Nephrology, Madras Medical College. We are extremely fortunate today, sir, to have you amidst us to give us the opportunity to learn from you. Next, I call upon Dr. Noble Gracious, Associate Professor, Department of Nephrology from Government TD Medical College, Alapura, who is also the Executive Director of K. Soto. So we are extremely eager to learn from both of you. And I call upon our next presenter, Dr. Likita from CMC Vellore. She'll be here to present the first short case. A note to the examiners and the audience, at the end of this presentation, there will be slides of the patient's biopsy displayed on the screen. So I request the examiners to spare some time for discussion of the slides as well. We'll be displaying the light microscopy picture. Since we don't have the immunofluorescence picture, we'll be just displaying the findings. I now hand over the stage to Dr. Likita.
Good morning, sir. Good morning, sir.
It's a short case.
Yes.
Short case presentation. So, fine. See to it, your presentation is concise, brief, and comprehensive.
Yes, sir. Good morning, everyone. Good morning, sirs. Today, I am going to present a case of a 45-year-old lady with nil prior comorbidities. She is a resident of Chittoor, Andhra Pradesh. History was given by herself and her husband, and it is reliable. She presented to our hospital in November of 2024 with complaint. She presented to our hospital in November of 2024 with complaints of fever which lasted for 5 days, 1 week prior to coming to us. This was followed by pedal edema which lasted for 3 days, followed by high colored urine for 2 days. Patient was apparently well till mid-October when she developed fever which was high grade, intermittent in nature, associated with chills and rigors. There were no diurnal variations of the fever she reported. She consulted a local physician for the same and was given oral medications to be taken twice daily. However, the fever persisted and hence she was given IM injections later for 2 days. This fever was not associated with any specific localizing signs like headache, vomiting, abdominal pain, or loose stools. She did not report any cough or chest pain during this time. She does not report any dysuria, flank pain, or rashes or sore throat. She denies history of recent travel or exposure to any sick individual prior to this. The fever she reports had subsided after 5 days of taking these medications, and following this she was able to perform her regular household activities. After 3 to 4 days of resolution of fever, she started developing pedal edema and facial puffiness, which was more in the morning. She first noticed the swelling in her feet, which was bilaterally symmetrical and progressed to involve the whole body in the next few days. This was not associated with any shortness of breath or apparent decrease in urine output. She also noticed that she had reddish-brown discoloration of the urine at the same time. The discoloration was present throughout the urinary stream. It was painless in nature, not associated with any passage of clots. She denies history of trauma, flank pain, or dysuria. She does not report any significant loss of weight or loss of appetite or any low backache or bony pains. She does not give any history of oral ulcers, joint pains, or photosensitivity, and denies history of NSAID intake and intake of indigenous medicines. So in view of these above complaints, she visited the hospital where she was evaluated and was told to initially have high BP recordings, and further was also told to have mild renal dysfunction and protein leakage in the urine. She recalls that her doctor told her that her creatinine was 1.5 at this time. She was advised a kidney biopsy for further evaluation. After undergoing the same, that is the kidney biopsy, she was started on medications and was told that these medications would decrease her immunity, and she was further told to take adequate precautions for infection prevention, and was also told to keep a check on her sugars at her hometown. However, after 2 weeks of taking these medications, the patient's symptoms did not resolve, and she persisted to have hematuria and also apparent decrease in urine output as compared to before. She came to the hospital again and was told that her creatinine had increased from initial 1.5 value to a value of 5 now. She was admitted to the hospital and was given an injection over 3 days, and during this time she also underwent a repeat renal biopsy in view of worsening creatinine. Following the biopsy, she was discharged after 5 days of hospital stay with oral medications. She recalls that this time, along with the previous medications that were given to her, she was given another tablet, and for which she was told to take plenty of water, and was also told to monitor her blood counts at her hometown. Following intake of these medications, she found symptomatic relief within 1 week, and in the next OPD follow-up, that is after 2 weeks, she was told that her creatinine was coming down, and it had come down to 3. She was advised to continue the same medications and review after 1 month. This is the short history, sir. Currently, she is doing well, has no complaints. She reports that her sugars have increased during the course while taking these medications, and she was advised insulin injections, but she was not willing to take them, so she was started on oral hypoglycemic agents. Should I move on to past history, sir?
A significant point to make past history, past, personal, family. Just you can finish it off in one.
I would like to put a little bit stress on the socio-economic history, sir. Because she lives in a kacha house in a village at her with 5 people residing in the family.
Okay.
So that is just one thing.
Anything in examination, any particular point?
Examination-wise, the significant findings that she was moderately built and nourished, and that she had pallor on examination. Otherwise, there was no edema or any significant lymphadenopathy which I could find. Otherwise, there was no other significant findings on the examination, sir.
Okay. Just tell the first diagnosis at the OP setting when you see this patient.
So this patient she's a middle-aged lady.
That all we understood. This is in your OP. The patient has already narrated the history. What is your working diagnosis?
In this patient, she reports history of rapid progression of creatinine with history of oliguria and also hematuria. So with this, considering this in mind, I would like to put my first diagnosis as, syndromic diagnosis as rapidly progressive renal failure, sir.
So patient is in your OPD and you don't know whether she is having a rise in creatinine. So what is your OP diagnosis before admitting to the patient?
Acute nephritic syndrome, sir,
Yeah.
in this patient. She presented with
What
mild
would be the
pedal.
cause of that acute nephritic syndrome?
In this patient, because it was preceded, these symptoms were preceded by fever, so I would go towards the diagnosis of infection-related glomerulonephritis, sir.
Would you like to consider IgA in this patient?
Yes, sir. Second would be IgA, yes.
Why
And
you preferred IRGN over IgA in this setting?
sir, it is not classically a synpharyngitic picture. So the fever was there 1 week prior, and after resolution of fever after 3-4 days, and then she started developing the symptoms. IgA is usually a synpharyngitic picture.
On admission itself, you decided on a biopsy. Why it's so? You know that it's likely to be a classical IRGN. Then what was the driving point for a biopsy in this case at the first instance itself?
So probably because of the progression of creatinine. We don't know the initial creatinine.
You did biopsy on the 3rd day of admission, right?
Yes, sir.
So you made a diagnosis of IRGN and you were making a biopsy on the 3rd day of your admission.
So
What rationale is that?
So from our differential diagnosis, second being IgA nephropathy, so we have to, in case it is IgA nephropathy, then she would warrant treatment.
Clinical presentation is classical IRGN, no? He had a history of fever, fluid overload, hypertension, vaccine creatinine, oliguria. So you made a diagnosis of IRGN. Will you do a biopsy on the 3rd day of admission which is labeled as IRGN? That is not my question.
No, sir.
And why you did biopsy?
Because in Indian scenario, we can consider other and middle-aged lady, we can even consider other diagnoses like lupus nephritis in this case. So we need to, or immune complex mediated GN.
So would you like to do some blood investigation before going ahead with biopsy?
Yes, sir.
Yeah, what would you
In this patient, considering the diagnosis of RPGN, I would like to send complement levels C3, C4, ANCA titer, MP.
So what was the pre-biopsy, these reports like? You are aware of that?
The patient
No,
does
you are
not know,
aware.
sir.
Okay, right.
Yeah, you are right. Your syndromic diagnosis is RPRF, right? So what do you mean by RPRF?
Sir, rapidly progressive renal failure, there is loss, there is a loss of GFR over days to weeks.
So what are the common causes for RPRF and what is the disease entity which you are envisaging in this particular scenario?
The common causes of RPRF, sir, include if we can think of any infection-related GN or IgA nephropathy or vascular.
So RPGN, no. Under RPGN, the etiological entities are there. Okay, RPGN, acute interstitial nephritis.
So we can divide that into glomerular, tubular, and vascular etiologies. So glomerular etiologies, as I said, include IgA nephropathy or immune complex mediated GN anti-GBM disease, pauci-immune crycentric glomerulonephritis.
Yeah, all that is fine, right? So out of these entities, if you are pretty clear that it is in the RPRF, the renal syndrome, you consider RPGN. You know the difference between the two, like RPRF is a kind of more of a clinical counterpart,
Yes.
the clinical component.
Yes.
The rapidly rising renal failure, worsening kidney failure. The histopathological compartment correlate for that is the crycentric glomerulonephritis. That explains this thing, okay. So what is the disease entity that you are thinking as the most common, most likely in this scenario?
RPGN, sir.
RPGN, due to?
Due to probably, since it was preceded by infection-related, I can give in order, sir.
Yeah, in the
Infection-related GN or IgA nephropathy or pauci-immune vasculitis
good.
or lupus nephritis.
Fine, that's good. So, how do you link the fever history with the pauci-immune, so-called ANCA disease?
In ANCA disease, they usually, I mean, they will proceed with fever, with lung involvement.
You are right. An infectious trigger can bring to surface ANCA disease. So, just because there is a temporal relationship between fever and the occurrence of the disease does not rule out ANCA disease. That point is very important.
Yes.
I agree with your points. How commonly you come across IgA nephropathy in the 5th decade of life? She is 47, 45 years.
IgA nephropathy is usually a diagnosis in the 5th or
You
4th or
can
5th
have
day.
in a big center, you can have wide range, but as the age advances, the likelihood for IgA nephropathy comes down. So I appreciate that it is not the first diagnosis, definitely, IgN. So as the age advances in IgA nephropathy, the chances becomes a little less likely.
Yes.
But having said that, we have patients even in the 6th decade and all that, but that's okay, fine. So in this scenario, how do you approach?
In this scenario, we will initially send all our blood counts and we will send our renal functions like urea, creat, electrolytes. We will
Always start with urine, right?
urine
Yeah, it was
analysis.
a red urine, so it was a hematuria.
So if in urine analysis we might find microhematuria, RBC CAS, granular
So
CAS.
here this patient has got macrohematuria. red
Macro.
urine, yeah. So how do you differentiate the RBCs of glomerular origin versus non-glomerular origin?
So glomerular origin hematuria is defined as more than 80% of dysmorphic RBCs, more than or equal to 5 acanthocytes, and
More than 5% acanthocytes.
acanthocytes,
Okay,
and
fine.
yes.
How do we check dysmorphic RBC?
So phase contrast microscopy, sir.
Have you seen that anytime?
I've seen pictures of it, sir, but I've not seen the
I've
microscope.
not seen phase contrast microscope.
Can you comment on RBC cast?
Yes, sir, RBC
What is
cast.
the significance of RBC cast?
So RBC cast means there is a leak. I mean, there is escape of the RBCs into the tubular lumen where it combines with Tannhorst-Fall protein and presents as a cast in the urine.
So it is almost 100% specificity,
Yes, sir.
for glomerular origin. So, but practically we are not able to demonstrate RBC cast very often. What are the reasons?
Usually because we keep it for a
You
long
have to
time.
Speak it through mic.
Because our urine is usually kept stagnant for a long time, so it might be lysed by the time we check it.
And again, the number of revolutions has to be
yeah.
lesser.
Yes, 4,000 RPM is the recommended
It has to be
revolution.
lesser than that. Fine, that's okay. So how do you proceed? What are the other investigations apart from blood biochemistry, ultrasonography? The specific investigations?
Yes, for in case of RPGN, we can, in this case, considering a differential diagnosis, then we can send complement level C3, C4, MPO and MPO and MPO and PR3 titers, and along with that, in case one of our differentials being lupus, we can send ANA and anti-dsDNA titers.
But the clinical examination, having thought of IRGN as the first possibility, so what should be the aim of your clinical examination?
So to look for any active infection which is going on.
So how do you do that? What are the common sites of infection which you have come across in IRGNs?
Usually we see in diabetic patients with occult infections, they might not know, in the feet and in the inframammary areas and groin area.
Skin infection can be there anywhere, no? Impetiginous lesions. And
In
skin
this case,
infection
would
is the
you like
commonest
to
one.
have any particular area of inspection? Because she gives some history of some important point which you are supposed to look. She have received IM injection.
Gluteal abscess.
Yeah, because the presentation is very profound. And what do you expect in the biopsy?
In this patient, because of
patient.
rapidly progressive crescentic GN, crescents is what I'd expect.
The examination is not complete. The focus of infection, how do you search? In fact, the most important thing in a patient with IRGN is diligent search for focus of infection. How do you do that?
So head to toe examination. So starting from the scalp, we can look for any occult like abscess. ENT.
ENT and in case if you are not able to pick up, please get the help of ENT specialist as well, because there are any number of instances where a silently sitting chronic mastocytitis has resulted in a very florid IRGN. Addressing that, bringing in complete resolution of the pathology. And asymptomatic sinusitis, asymptomatic mastoiditis, and so on. How about urinary infection? In the urine, I thought you'll ask for infection.
Yes.
Can UTI lead on to IRGN?
Yes, sir.
Yes, of
There
course.
are reports. Yes.
Then, in the careful auscultation of the lungs for picking up the infection in the lungs. Anything else? Echocardiography?
Endocarditis, sir. Yes.
Okay. So, head to foot infection, the gynecological infections, and gastrointestinal infections, respiratory infections. So, this is the trend change that we are seeing in the IRGN. The erstwhile post-streptococcal glomerulonephritis, the entirely different clinical phenotype, right? Predominantly affecting which age group? Initially, many decades ago, the concept of infection-related glomerulonephritis was
Childhood.
young,
Young,
pediatric,
yeah.
and typically the impetiginous lesion, skin infection, and so on. Now it is a little different, Fine. At this juncture, I would like to highlight on the historic paper from CMC Vellore on IRGN. The clues for getting something from your own paper.
Sir, it basically, the
So
paper
what are
published
the,
from...
before going into the details of that, what are the unique phenomena of that paper? It has got a great acclaim, right? International literature, because that is the longest the cohort of IRGN ever published in the history of nephrology. That's it. How many patients were? Sony John. John is first author. 502. 502. In fact, the editorial commentary, you have read that, right? In CJAS.
I have
Yeah.
read.
So the longest, the paper with the largest number was from Sami Nazar, and this is more than 5 times that the largest series ever published. So that's it. Okay. So how were the patients categorized in that paper?
Sir, not very sure.
Yeah, I would suggest all of you please go through that. Para-infectious, post-infectious, okay, and peri-infectious. Okay. So nicely categorized. Fine that. So still we have not ruled out, even though IRGN is the first possibility. Second possibility, very close possibility is
IgA nephropathy.
ANCA disease. IgA, I'll put it as the third one. Still, do you consider lupus in her?
Yes, sir.
Is there
One
any
of-
phenomena to consider lupus?
She is a middle-aged, still menstruating lady, so lupus can be considered, but lower down in the...
Still there is a possibility, but it is less likely compared. Considering the age and lack of all other phenomena, you have elicited a detailed past history, nothing to suggest and so on. Okay, still. Okay. So in keeping these in mind, how your complement analysis will help?
So in patients with lupus nephritis C3 and
How
C4,
about IRGN?
In IRGN, only C3 because complement pathway, alternative pathway is affected.
No, C3 will be low.
Low, yes, sir. Whereas in lupus nephritis, both alternate and
Both C3, C4 can be low.
can be low.
And
And along with that,
ANCA
ANA,
disease, it is
anchor disease also, it might be low sometimes, sir. Not always.
very, very rarely
Very
come across
rare.
hypocomplemia. Otherwise, it's not a phenomenon at all. So, how do you define what classification, definition classification you adopt to make a diagnosis of IRGN? So, clinically you are finished, lab investigation is finished, still biopsy is not there. At this point of time, to make a diagnosis of IRGN, what are the diagnostic criteria you follow?
Sir, for diagnosis of IRGN, we should have a history, history-wise recent infection history,
No,
presence of...
whose diagnostic criteria is it?
I don't know the
That's what
names.
we follow now. Sami Nazar's criteria. Sami Nazar's criteria. But the problem with that criteria is that how many criteria are there?
5 criteria, we should
So,
satisfy more
out
than...
of 5, 3 are in a biopsy, right?
Yes, sir.
So otherwise we cannot make. So what are the 5 criteria?
First is presence of prior history of fever, followed by presence of
Not
endocapillary
fever, not fever, evidence for
infection.
infection, concomitant or antecedent infection. Okay.
Then presence of hypercellularity in
No,
the
that's not biopsy.
Okay.
Biopsy, 3 criteria there. The lab parameter,
hypocomplementemia.
hypocomplementemia C3. Okay. So
Um,
one is the clinical, one is the lab, the other 3 are histopathology. What are they?
Hypercellularity, glomerular hypercellularity, presence of crescents, glomerular hypercellularity, and IF wise C3 dominant staining, and EM wise presence of humps in the GBM, subepithelial layer.
Subepithelial hump. So one light microscopy, one immunofluorescence, and one.
EM.
So shall we just go through the biopsy now, or at the end of discussion we'll go through? So light microscopy, proliferative GN, right? Proliferation meaning endocapillary proliferation here. It is not just mesangial proliferation. So proliferation is a very common term, right? It can be mesangial proliferation or parietal epithelial cell proliferation or endocapillary proliferation. Here you are meaning endocapillary. Other things may be there, not be there. In addition to that, there can be infiltrating neutrophils, leukocytes also can be there. Okay, fine.
This is a light microscopy picture showing H&E stain of single glomes with tubules around. There is endocapillary hypercellularity which is seen in the glomerulus with that one, the right one does not show any crescent formation. The
Left side is the first biopsy, right side is the second biopsy.
The first one still shows some endocapillary hypercellularity, but no crescent formation. But the second one, the left side one, shows that and again endocapillary hypercellularity with cellular crescent formation.
Dr. Likita, you can use the pointer.
This is the crescent.
Describe the first biopsy.
It is a light microscopy picture with
The endocapillary proliferation.
sir, if in here we can see more than here also, and here.
Show me one neutrophil in it. You have that? Yeah. Is there any neutrophil in it? Do you expect any neutrophil in it?
Yes, sir.
You expect?
Yes, sir.
Is there any? How's the capillary lumen looks like? Okay. How's the capillary lumens look like? It's obliterated or it's open? Use mic.
Here, a few of them have collapsed, sir, but here everything looks collapsed.
How is the Bowman space in first one?
I mean, it is
Good.
visible.
How is tubules?
There is a loss of brush border, sir, in the proximal cannulated tubules, mild loss of brush border.
You were able to identify a PCT. Oh, it's very good.
SDC.
Right. Show me one PCT because I rarely see PCT by. Anyway, it's fine. So you are given an option of IF versus EM. What would you do? Only one you can do. IF or EM.
IF.
IF. So what do you expect in the other case?
C3 dominant staining, sir.
Why? You are expecting IRGM.
Yes, that is.
No immune complex you are expecting.
Can be immune complex GN also, sir. So I would test for
Why you
immunoglobulins.
suddenly went in for C3 dominant IF finding in this case?
Because my first
classical
differential.
history of IRGM is there. C3 can be present, but what do you expect usually? in
Immunoglobulin also I would
No, what's the
expect it to be.
classical presentation of IF finding in IRGN?
C3 dominant staining, sir.
C3.
But immunoglobulin staining can also be present,
And also be present.
but as at a lower intensity.
Fine. Yes. So what are the immunofluorescence finding?
The immunofluorescence finding in the first biopsy, C3 was is 2 plus, location is granular and mesangial. IgM is trace, location is granular mesangial.
Fine. So it's only C3.
So
So
it
does
is
it
C3.
satisfy Sami-Nazar criteria, C3 dominance?
Yes, sir.
Yes, of course.
Yes.
So are you sure now you can make a diagnosis of IRGN with this? What are the complement level, anybody? C3? Was it low? Fine, okay. So are you fairly convinced that it is
Not yet.
IRGN?
C3 dominant staining is there.
So
But-
if there is a C3 dominance with endocapillary proliferation, what is the differential diagnosis?
Sir, it can, infection-related GN is the first differential. It can still be immune complex mediated GN also.
So infection-related glomerulonephritis is not immune complex.
It is. But it is C3 dominant.
So we'll come to that later. Fine. It is the prototype of immune complex. GN is IRGN, right? Okay. So what is the other entity you are thinking in terms of
C3, C4 was normal, sir, as projected.
normal?
So how do you revisit this piece? You have complement level, you have a IF showing C3 predominance. Now how you revisit the case?
With these reports, sir, C3, C4 being normal, could be that infection has already resolved, so that could be why it has become normal. Whereas anti-streptolysin O and ADNB titers are both on the lower side, which could suggest a post-infectious etiology in this patient, post-streptococcal etiology.
No, it is lower meaning it does not favor your diagnosis
Sir,
of.
favor the diagnosis.
But comment on all this. I say it is still IRGN. How do you argue?
Because of a biopsy,
Yes, sir, because it can be, it's not just only streptococcus, right? It can be any other
it can be any other.
bacteria or even other non-bacterial microbes also. So, in ASO titer will be significantly increased only when you come across streptococcal infection. And can you have normocomplementemia and IRG?
Yes, sir, we can have.
Rarely. So there are certain explanations and beyond the scope of this particular discussion. That does not rule out. That's why the criteria. So now the electron microscopy assumes all the more significance now, right? Out of these 5 criteria, at least 3 have to be passed. There is no hypocomplementemia. There is endocapillary proliferative glomerulonephritis, 1 criterion is there, and evidence for infection is there. And but you need one more, right?
IF,
And say,
I mean EM.
C3. And then how about
IF and
electron
EM.
microscopy? And you said hump. What is that hump? Where do you see the hump in IRG?
Subepithelial humps.
Subepithelial. Again, what is the caveat in that? Are you able to, how commonly you come across these humps? Is it always possible to demonstrate a hump there?
Not very, I mean, it is not usually seen, sir.
Yeah.
And
So the explanation is that, many times it is not seen because by the time we decide to do biopsy and already there will be a resolution. That's
Yeah.
one explanation.
it's absorbed.
And again, please remember, if a subepithelial hump is there, it is in more favor of IRGN, but it is not 100% specific for IRGN, even in C3GN. So what is the closest differential diagnosis for this? Still, you have not come up with that.
Based on the lab findings, sir.
How about
poss-
C3GN? Which other pathology where there is C3 dominance and then proliferative glomerulonephritis?
C3GN. So C3 glomerulopathy can further be divided into dense deposit disease or
That's what,
C3G.
I was expecting that actually. No, C3GN. Can it be triggered by an infection? C3GN, can it be triggered by an
Yes.
infection?
Yes.
So in that situation, how do you differentiate between the two?
Um,
And why we have to differentiate between the two?
So, C3GN usually requires initiation of steroids, whereas IRGN can be, there is no indication for steroids in patients with infection-related glomerulonephritis.
So how do you differentiate the two?
Sir, based on IF, so in infection-related GN, C3 dominant staining will be there, but IG,
Here, in this patient.
um,
Now theory is over. Let's come to discuss only this particular patient.
so C3 is the dominant staining, but there is even IgM trace.
IgM trace is a non-specific
Non-specific.
trapping. Always remember,
So it,
just a trace to 1 plus. If that particular entity is not congruous with the diagnostic possibility, simply ignore. Renal pathologists, they say that there can be non-specific trapping. Trace and all, I don't consider.
so C3 dominant, then we will go towards C3GN
Is it
or
possible
dense
to have
deposit.
C3GN with this scenario?
Yes, it is possible.
How many minutes more? 10 more minutes. So, what is the consensus statement for making a diagnosis of C3GN by Service et al.?
Sir, C3 staining on IF with minimal or no immunoglobulin staining.
No, it's very, very classical description of C3 dominance. If any other immune reactant is present along with C3, the C3 should be at least,
More than or equal
it
to
should be greater at least by 2 orders in a scale of 0 to 3. So, it fits into that.
Would you like to order any special investigations in this case? Now you have IF here, you have clinical picture, and would you like to have any more investigations
EM, yeah,
other than EM? This is just a pattern. LM is a pattern. You have an injury, you have a C3 predominant deposit. How you evaluate? You can't just label it as C3 gene and just forget it. How you evaluate? What do you like to explore more?
Sir, we have to rule the other causes of MPGN like autoimmune etiology and monoclonal gammopathy and infections again.
Infections like very important infections, which because you are going, if you are planning in this as C3 gene, you likely to immunosuppress, no? So you need to do other
Like
infections screening.
beta hemolyte, staphylococcal
You
infections.
don't do any viral screening for this?
Yes, sir.
Which one?
Um,
Which can present with C3 gene? Common viruses only, which we do as a pre-op evaluation for any test.
CMV, right there. Sorry, not CMV.
Okay, how did you immunosuppress this patient?
This patient initially she said that she was started on a single immunosuppressant, sir. Followed by the second biopsy, I mean, then she was started on probably 2 immunosuppressant. According to what? No, she does not. She was told to take adequate precautions because it would reduce her immunity. And with the second medicine, she was told to hydrate well and told to keep her total counts in check. So probably that was cyclophosphamide, oral
Okay.
cyclophosphamide.
Fine. Again, coming back to this, with the second biopsy, comment on the immunofluorescence.
In the second biopsy, C3 is 2 plus with granular mesangial and
Fine, C1q.
C1q is 2
So what
plus.
is your diagnosis now?
So that would suggest IgA, IgM, kappa, lambda are all negative.
So now the distinction between IRGN versus C3GN. So with the presence of C1q,
C1q would suggest an autoimmune.
what I mean, okay, but in this scenario, between the two,
Uh,
so definitely more in favor of IRGN because C3, it's a disease of dysregulation of alternate complement pathway, exaggerated alternate complement activation. So there is no business for C1q to be there. Of course, recently there is an article that presence of C1q does not rule out C3GN. I will not confuse you with those extra arguments. But as such, 2 plus positivity of C1q on par with C3 that rules out diagnosis of C3GN. Otherwise, how to make a differentiation between the two? It's very difficult. Arbitrarily, almost all the centers, we follow some kind of a pattern of distinction. When there is a hypocomplementemia C3, if it is IRGN, over a period of time, it has to normalize. If there is a persistent hypocomplementemia C3, even beyond 12 weeks, we consider it as C3GN. It's very arbitrary, very, very arbitrary, but that is how we proceed. Okay. Now the most important point, final point, the role of immunosuppression, steroids and other immunosuppressives in IRGN.
In IRGN, there are no studies which show that steroids are effective. The wait and watch strategy is.
Have you come across any RCT, randomized controlled trial on steroids in IRGN? That's from Madras Medical College. No? In fact, it is the only RCT.
Yes.
What is the conclusion in that?
That steroids are not as
Not
beneficial.
effective, not effective, but the caveat in that study is that we have excluded crescentic glomerulonephritis and we have excluded IRGN with severe kidney failure warranting dialysis and so on. Okay.
How much wiser you have become after the second biopsy from the first biopsy? You did do 2 biopsies, no? How much wiser you have become after second biopsy? Or you have become more confused?
I become more confused.
You have become more confused.
Yes.
Would you again like to consider any other disease other than C3G in this patient? Do you like to rule out SLE again?
Yes, sir, I would.
C1q.
Yes,
And
because of
also
C1.
you have to remember about APLS syndrome. Actually, this is also present like this. C3, C1q. If you have a C4 deposit along with this, what would you think of?
C3 and C4 immune infection
Do
related
you have any
only.
disease with isolated C4 predominance
Cryoglobulinemia, sir.
and
Not very sure, sir.
And final point, whenever you come across crescentic form of IRGN, the prognosis is not that rosy compared to general IRGN, number one. Number two, it is mandatory to rule out infective endocarditis because very often infective endocarditis associated IRGN will have a crescent. And third important point, whenever you come across very minimal presence of C3 and no immunoglobulins and not much of endocapillary proliferation, little bit of glomerular tough necrosis with crescent, mandatorily you have to rule out onco disease because it can sometimes we may get before by the temporal association of fever, infection trigger and so on.
Yes. Good. Thank you, sir. Thank you, sir.